information about the disorder. Schizophrenia is a chronic brain disorder. It affects what we estimate to be less than 1% of the U.S. population, although due to its complex nature, it can be difficult to get an accurate estimate. It's debilitating. It can have some very severe side effects. It generally appears in early adulthood. Similar rates of occurrence between males and females, although generally earlier onset in males, late teens, early 20s. There's no known cure, so treatments are really focused on symptom management, coping skills, and how to function in daily life with the symptoms of this disorder. It's frequently comorbid with other psychiatric conditions. There's a lot of symptom overlap that can make diagnosis difficult. And substance abuse is the most commonly used coping tool. Those affected with schizophrenia are generally not dangerous or violent, even though frequently this condition is portrayed in its extreme in media and popular culture because that's interesting, that sells movies. But the fact of the matter is this contributes a lot to the negative stigma. There's a lot of good research that suggests that when schizophrenics are violent, it's more likely due to their comorbid substance use than it is to their psychiatric condition. And I've got some good references in the back to that. Fazell, 2009, Malik and colleagues, 2016. Some really interesting research. Schizophrenia has a wide variety of symptoms that we can place into four main categories. So there's positive psychotic symptoms, which is generally what people think of when they think of schizophrenia. That's hearing hallucinations, hearing voices, paranoid delusions, exaggerated or disordered perceptions, beliefs, and behaviors. Then there's your negative symptoms, which may include a loss of ability to take initiative, to initiate plans, maybe a poverty of speech, inability to express emotion, anhedonia, a loss of pleasure. There's also disorganizations, symptoms, which is mainly mental, confused and disordered thinking and speech, or maybe just word salad, a confused jumble of words coming out, difficulty with logical thinking, so it could be a loss of ability of executive function, sometimes bizarre and abnormal behaviors, or even physical movements. Then there's impaired cognition, which could include difficulty with attention, concentration, difficulty remembering, and declining educational performance is also likely.
So I'm going to be talking a little bit about women and schizophrenia in general. There is a lot of studies out there, but not necessarily in the U.S. A lot of the ones that I saw took place in India or in China, actually. So a lot of the information that I found are off those articles. So in a study I found states that there's no significant gender difference in the prevalence of schizophrenia, whether that be in women or men. Although women's health is closely linked to their status in society. This was found specifically in the study done in India. They found that women's status in society made a huge difference as far as mental health in general when it comes to women. Suicide appeared to be more prevalent in women with schizophrenia, while male patients showed more of a severe deterioration over time. The World Health Organization described schizophrenia as a disease for young men. The article that I read compared multiple studies in regards to the prevalence of schizophrenia in men and women. Most studies did show that it was more common in men, but there was some that said it was more common in women, but majority was men. Women with schizophrenia tend to be more hostile, physically active, and more emotional than men. Women experience more paranoid and anxiety symptoms. So some more information. There is a higher average age onset for women, but as far as the time between onset and their first hospitalization, it is the same for both men and women. Men and women require different levels of doses for antipsychotics. A 3-year study was conducted by the Schizophrenia Outpatient Health Outcomes, which observed the health outcomes in regards to antipsychotic medication. This study found that gender played a significant role in predicting the response based on the Clinical Global Impression Scale, as well as an increasing quality of life. The medication that showed the biggest difference was clozapine. Also, interesting fact, 20 to 40% of homeless women suffer from some form of psychotic disorders. They didn't specifically say how much of that was women diagnosed with schizophrenia, but it generally spoke about psychotic disorders. And the last part that I have is in regards to women diagnosed with schizophrenia and pregnancy. Women have a higher rate of unwanted or unexpected pregnancies. Some women with schizophrenia are in denial about the pregnancy. They may not fully understand the changes that are going through their body, or even recognize going into labor. Some risk factors for the unborn child: lower birth rate, intrauterine growth retardation, premature death, and preterm birth. It did say that this is not for everybody. With the right knowledge and the right tools, these risks can be reduced.
So one assessment tool that you can use with patients who have a history of schizophrenia, or if you just want to assess to see if they're displaying symptoms of the disorder, is the Positive and Negative Syndrome Scale. For the rest of the video, I'll just refer to it as PANS. This is a standardized psychometric tool used for assessing positive and negative symptoms of schizophrenia. So when using this, you'll be able to ask the patient questions on positive symptoms as well as negative symptoms, and it differentiates between the two, so it can kind of give the clinician a guide as to which symptoms they're displaying, or if they're having more positive or negative symptoms. This is a 30-item rating instrument, and it evaluates the presence or the absence of symptoms, the severity of the symptoms, as well as other psychopathology. So after you ask about the positive and negative symptoms, it also asks about depression or anxiety, just other symptoms, so that the practitioner can get a good idea if the client is experiencing anything else. The items are rated on a 7-point scale. 1 is being absent and 7 is being extreme. And when working with the patient to see if they are displaying any of these symptoms, the clinician is supposed to read the definition for 1 through 7. That way the client can kind of know if they are experiencing these symptoms and how severe that it is. This is a widely recognized and used assessment tool for schizophrenia. It has been used in numerous clinical studies. It has reliability and validity. It's been around for a while. I think some of the earliest articles I found for this assessment tool were in the 1980s. So it's been used widely and it's well known. It can really help practitioners get a picture of how the client is experiencing these symptoms and how it's affecting their functioning. So continuing about the PANS, I know I mentioned this earlier, but one of the earliest studies was conducted by Kay Opler and Lyndon Maber, and this study supported the instrument's reliability, validity, construct validity. So it's been tested with a bunch of different areas and has been shown to measure what it's supposed to, and you can get the same results if you take it multiple times. So with this assessment tool, not only does the clinician take into account the patient's score, but reports from family members or other medical providers and therapists are considered. So this can help get outside information that's not coming just from the patient, because sometimes the patient might not perceive their behavior as problematic, or if they're hearing something, they might think that it really is there when it's not. So getting information from other outside people can be really helpful. This interview is typically administered by a clinician and takes 45 minutes to complete, so it's kind of lengthy, but it goes over a lot of good information that's useful for the clinician. So here's a picture I found of the PANS rating form. You can see that the layout it has 3 different boxes, and the first box, P1, P2, those are the positive symptoms that you're going to assess for. The N stands for negative symptoms, and then the last box has the G, so that's going to be other psychopathology that the patient could be exhibiting. So some of the examples of the positive symptoms it asks for are delusions, excitement, hostility. With negative symptoms, there's going to be blunted affect, poor rapport, stereotyped thinking. And then for the other psychopathology symptoms that you could assess for, they're going to ask the patient about feelings they may have, such as guilty feelings, anxiety, depression, poor attention, preoccupation, poor impulse control. So this is really helpful because it asks a broad amount of questions. So you're not only looking for the schizophrenia symptoms, but other symptoms that could be interfering with the disorder or making the functioning more severe. So with the rating scale, it's going to go from 1 to 7, 1 absent, 7 being extreme. And when the clinician is asking the patient if they're experiencing any of these symptoms, what they'll do first is for P1. They will say, "Are you experiencing any delusions?" And they will give a brief definition. So with delusions, it has beliefs which are unfounded, unrealistic, or idiosyncratic. And so then they're going to read the definitions for 1 through 7. So for example, number 1 would be absent. The definition does not apply to you. And then they would go through the rest. But another example I'm going to give you is 7, which would be extreme. And so when you're presenting this to the client, you would just read the definition off exact as they have it. So this one says a presence of a stable set of delusions, which are either highly systemized or very numerous, and which dominate major facets of the patient's life. This frequency results in inappropriate and irresponsible action, which may even jeopardize the safety of the patient or others. So that was just for the first positive symptom. You would do this for all the symptoms in each category, going over all the definitions, so you can see where this is very in-depth and allows you to talk with the patient about all of the symptoms and see how they feel like they are experiencing them.
So a slightly different approach than Annie just discussed involves an assessment called BCATS, Brief Cognitive Assessment Tool. And deficits in cognition have been found to contribute to barriers for individuals with schizophrenia, increasing their functioning. So in other words, their difficulties in cognition keep them kind of stuck in whatever barriers of schizophrenia are affecting them. So those barriers, one of the main areas identified is that it keeps them from gaining employment, and so much comes with employment. Independence, self-esteem, building connections, friendships. So some of the deficits that have been identified in cognition within this population are verbal memory, attention, executive functioning, among others. And people are finding, specifically psychosocial and cognitive rehabilitation researchers are finding non-pharmacological approaches to addressing these deficits. In other